Good afternoon, everyone, and welcome to our second session of the Global Social Prescribing Summit, Access and Equity in Social Prescribing, exploring solutions to reduce barriers and improve inclusivity. And I'm absolutely delighted to welcome my panelists here today, Jaye Charles, CBE Start Change, Andy Cox from the north of England and Signal. I'll be speaking to Manuela Boyle, who's joined us all the way. She's probably very late in Australia. Maurizio Morini, my colleague in Italy, and we're looking forward to this session. Let me just set the scene. We do face enormous barriers in healthcare. I think we've learned from COVID the opportunity to engage with communities locally. And we've seemed to have retrenched from that aspect of our work over the last few years since COVID. I think the Social Prescribing Alliance and the work that we're doing is to go back into primary care. And you've seen the NHS recent 10-year plan, which mentions neighbourhood health, for example. So we're looking at a new way of engaging communities at scale. Let me just bring in my panelists. I'll start with Manuela, who's in Australia, just for some short introductions. Manuela, the floor is yours. Go ahead, Manuela. Can you hear us, Manuela? Maybe we have some technical difficulties with Manuela. Maurizio, well, let's go to you in Italy.
Oh, thank you, Gareth. Thank you to everyone and all the hosts. It is an important event in Italy. With Gareth, we are working since April 2024 to try to introduce the fantastic purposes of World Health Innovation Summit. We did the first event in the month of May of 2025, and we are programming a lot of initiatives. We have a lot to do, as we know, but perhaps Italy is not different from the rest of the world, but we will speak about it in the discussion. Thank you to everyone.
Thanks. Let me go to London. Julie, it's a pleasure to see you.
Hello, everyone. Hi, I'm Jaye Charles, and I am very well known to be somebody that develops community engagement across the UK. I am also a ministerial advisor, and I am a founding member of the National Institute of Clinical Excellence, which we all know as NICE. I have an organisation called Start Change, and that deals with social justice for communities, particularly Black males with mental health in the criminal justice system.
Thanks, Julie. Andy, in the Northeast, great to see you.
Hi, thank you, Gareth. Good morning, everybody. My name's Andy Cox. I'm a director of a social enterprise called Signal. Signal happens to be a change and transformation tool that works at an individual and a community level. And we've been working with our movement or network across the UK of 100 plus organisations for 8-9 years. And we've got a growing movement within the social prescribing world to hit the mission that Gareth has eloquently described earlier. Thank you.
Thanks. Hi, Manuela. Hopefully we can hear from you. I know the connection is not great. Can you hear us? I know the connection is not great. Okay, what we'll do is, look, we're having some technical problems with Manuela's signal at the moment. So what we'll do is, let's start with Julie. Julie, if you could possibly tell us a little bit about, like, how do we ensure that social prescribing services are accessible to marginalized and underserved communities? I mean, you mentioned this is sort of key to your work. If you could sort of like outline, how do we do that?
It's a matter of knowing who your community are And so it really is about learning the demographics of communities. It's about building and having a rapport with your community. It's about considering what isolation means to communities. And when we talk about like marginalized and underserved communities, and accessing services, um, social prescribing, so to speak. I think that coming from a view, let's say London, for instance, London has a centre, and that centre does not have marginalised communities. It has communities that are marginalised by systems, and it's the systems that are actually marginalising communities. We have communities that are marginalised in rural areas too, and they are really, really marginalised. And so I think that it has to be around targeted outreach, um, multifaceted approaches, focusing on the social determinants of health. Um, in order to reach people and welcome people in, welcome your communities in, you have to be able to communicate with communities in the way that they communicate with each other. And it's about making sure that you have the right social prescribers in the right place at the right time. It's also about making sure that the voluntary sector, the voluntary and community sector, and charities are working directly with, and not on the outside, but directly in the centre with statutory sector public services. Because without that happening, you won't know who your community are, you won't know where the community are, and you won't know what the community need is. And so I think that it's all about collaboration. Access has got to be around collaboration and outreach and utilizing existing networks and community leaders, particularly community leaders of faith. That's really, really important. Um, I think that we also need to make sure that social prescribing is something that not only is in the community but ripples outside of communities, so that more and more people hear about it, more and more people can access it through the ways that I've just mentioned.
Thanks, Julie. I mean, you're setting the scene. Let's see if we can bring Manuela in. I hopefully I know there's a delay, but Manuela will pause and hopefully you can speak to do a short introduction. And
Hi.
maybe go ahead.
O- Okay. Look, I apologize. Okay. I do apologize. The connection is really terrible. I really do think and feel very far from all of you, even because of the connection. So I hope you can hear me. It's a great pleasure to be here, and my scope, and of course I was invited, I've been invited to participating here and presenting some or referring to some of the most perhaps interesting initiatives in the Australian South Pacific region, um, and in
I think unfortunately we're losing Manuela. The signal doesn't seem to be great. So Andy, my apologies to everyone
is,
tuning
well,
in.
they're all very different and great, really.
Andy, I'll come to you just from your context. How do we ensure, what role does data play? I mean, following on from Julie's perspective, what role does data play in identifying gaps in access and designing equitable interventions? This is what Signal is doing very much in getting into the marginalised communities.
Absolutely, Gareth. And I think I'll try to mirror what the users of Signal would say to you if you were asking them the question. It's really about bringing a sort of critical bridging role into social prescribing, showing both where access is failing and how to design responses that are fair and effective. We know things like traditional assessment systems measure eligibility, severity, and none of the solutions actually ask the individual what matters to you, and that's where we start with data. Let me give you an illustration. Data works at two levels, basically, at a micro or a personal level, where an individual would respond to a series of indicators and build what we describe as a life map. It's their data on one sheet of paper that helps them reflect, look at their assets, but also start telling their narrative, their story, so they can identify what things they want to improve in their life and often the barriers to progress. So, for example, if I said to you dental hygiene or poor dental hygiene was the most significant barrier to people who are languishing getting back to work, then a lot of social prescribing providers are working on helping people access dentistry to help them get back to work. It's about finding root causes. If I said that 80% of people with a common mental health problem had the root cause in their problem associated with debt or social isolation, then you work on the root cause, and no amount of cognitive behavioral therapy or counseling is actually going to eliminate your problem. So this is how data is used to better understand personalized, actionable plans where you're actually asking the question, what matters to me? And the second level is about looking at data from a macro level, where aggregated data and user stories and narrative reveal patterns of inequality, and groups of communities can work on these to better target interventions. So that it allows a sort of a co-design of solutions. If I was to sort of illustrate that, recently we're working in South Tyneside with a fabulous social prescribing organisation called Northern Rights, and all of their users turned up to an event with their life maps in their hands. And we had data on the wall illustrating through infographics and spatial data where the opportunities and threats were. And this young man turned up with his life map. And in this event, we had public health, we had housing associations, we had everybody who was part of the ecosystem. This young man held his life map and likened his indicator on poor household insurance to the indicators on the wall. And the policymaker from the housing association said, well, I can fix that. And went that afternoon to Aviva Insurance and got affordable household insurance for anybody looking for employment in South Tyneside for £1.50. So the democratization of data is enabling individuals to use their data to inform policymakers. So this is illustrating how data works on an individual and community level. And I'd just like to leave you with this thought that data is really the lens which we see inequity clearly, both at a personal and a community level. And it acts as the blueprint for designing and co-designing fair, inclusive social prescribing interventions. So, like other people on this line today, we're working with partners to make life better, but from the perspective of what matters to me as an individual entering into the social prescribing world. I hope that answers your question, Gareth.
Yeah, thanks, Andy. Thanks for setting the scene. And I think it's very important because social prescribing is being adopted like all over the world at the moment. So that's why I wanted to talk to Maurizio. The next question, because we earlier this year, just a couple of weeks ago, myself and Maurizio were in Bologna and we launched with a number of partners. And I've had a number of emails actually since I've got back from Italy asking me and Maurizio, how do we engage with social prescribing? So my question to Maurizio is, and we have this on a regular basis, Maurizio, when we speak on the phone, because I'm Irish and Italian. So how do we overcome cultural, linguistic, or digital barriers to participate in social prescribing programs? So Maurizio, the floor is yours.
Thank you, Garrett. Thank you, everyone. So I want to give an answer in a very strict way because the topic is so huge that we could speak, as we know, a lot. So I think that to overcome cultural, linguistic, and digital barriers in social prescribing, we must act on multiple interconnected levels with a transdisciplinary approach. The first thing is to listen to local voices. We have to build a culturally responsive design because the idea is that social prescribing must be built with, not just for community, with, not just for. So in Italy, especially where the regional identities are deeply rooted, it's essential to co-design interventions with local actors, cultural association, faith-based association, community leaders, to ensure, and all the citizens, to ensure the services reflect local values, needs, and languages. We are doing it for other topics. We have to do even for health and global health because it's not a topic for specialists. We have to go out of this normal view. This bottom-up approach means trust, relevance, and so on. Because when people see themselves reflected in the solution, they are more likely to engage. It's a normal truth, but it's not so common to find it used. The second topic is the linguistic inclusion. We have to translate not words, but meaning, especially in the care assistance. We see that people translate words, but we have to build a bridge about the meaning of things. So very well done multilingual materials in areas with high migration, plain and accessible Italian in public health communication, avoiding bureaucratic jargon. We could see a lot of examples, but we have no time to be on it, and train link workers and health professionals in intercultural mediation. You remember the transdisciplinary approach, because they can understand and convey the deeper cultural meanings behind health need and behaviors. The third point is bridging the digital divide, because we have to add human support to simple tools. Digital exclusion remains a serious risk, especially for aged people or low-income population and some rural areas. We have to pair digital tools with face-to-face or phone-based options, preserving human content. We have to use community hubs, like, for instance, libraries, social centers, pharmacies, of course, as physical entry points for digital onboarding. We have to promote digital literacy programs to link social prescribing pathways, helping people gain confidence while connecting to services. The fourth and last point for me is building capacity through the empowerment of local actors. We must invest in training and empowerment of local link workers, peer supporters, volunteers, as WIS is doing, ensuring they are equipped to identify cultural and social barriers, act as cultural mediators and advocates, adapt the pathway without losing core health goals. If we train people from the community, we can create a long-term sustainable bridge between system and individuals. In my personal opinion, we have to invest a lot even in health medical management with a transdisciplinary and holistic view too, in a multi-stakeholder vision. I wrote an article some weeks ago about this. Today, the vision is care and diagnosis and care model with one stakeholder, uh, the firm for health management. Is not possible. We have to create a multi-stakeholder vision, including the citizen. So, for me, new medical business high-level course, including all the topics I described, even for other specialists, not only technicians, must be created. Because it's not only health management is not only a problem of cost control and optimization. It's a new future of real health and prevention that we have to build in. And it's for all of us. So, to go to the end, overcoming the cultural, linguistic, and digital barriers requires genuine listening, local co-design, simple tools, and educational alliance and innovation rooted in the communities. Because social prescribing, in my opinion, is not a healthcare model. It's inclusive social process that restores dignity and voice to people wherever they are. And in Italy, as in the rest of the world, we need it very, very much.
Okay, fantastic, Maurizio. I couldn't agree with you further. I think I had a meeting this week with Julie, and I had a meeting yesterday with Andy and colleagues in the Northeast, and we talked about the similar processes of making sure that we involve communities, building out these systems, and data plays a huge role. Manuela, thanks for joining us. You look a lot better, a lot fresher on this screen. Let me hand over to you to do the short introduction, please.
Thank you. Look, thank you, and thank you for your patience. I'm not sure why we had such a poor connection. You never know; things happen right at the wrong time, really. So I'm sorry that I missed some of your presentation, and I look forward to listening from you again. So I just wanted to briefly contribute really to this discussion by highlighting that there are some good initiatives this side of the world. And in particular, there are three I would like to mention quickly. One is it's a Royal Commission into the state of Victoria. Victoria is one of the states in Australia, and it's about the mental health system. So it's called Mental Health and Wellbeing and locals, and it's all across a state, which is really as big as the United Kingdom, by the way. So it's really quite a large territory. And we're talking about fighting or getting on top of the loneliness and so mental health issues impacting the elderly population, which is obviously a similar scenario in United Kingdom or Italy or any other country really. And so there are, in fact, so elderly, in fact, refer to their GP, the primary care practitioner, for mental health issues, or other organizations are then liaised with community-based initiatives, which vary a lot. There could be art, creative groups, walk in the park, connecting with kindergarten children. So children go visit elderly people in homes. And therefore, this entire issue related to loneliness and separation is just wonderful. I think it's an initiative that everybody just love, and I'm sure it's probably trickling around the world. The other one is about impacting Aboriginal and Torres Strait Islanders people in Australia who are also affected by a number of health issues, dietary, mental health, lifestyle, etc. And Indigenous population have a layer of problems, of course, impacted them perhaps a little bit more than the general population. So therefore, what has been come up to be quite a good solution, so far so good, is particularly dedicated organizations are spread out throughout the entire continent of Australia. And those are run by GPs, primary health care practitioners. However, in the same healthcare settings, you have Aboriginal and Torres Strait Islanders representatives who then improve that connection, support the connection, cultural connections, and language connection, by the way. And they then, in turn, they are then referred to other organizations helping Aboriginal Torres Strait Islanders people with non-pharmacological support, but from the point of view of really social support. So problems, problematic issues impacting, for example, self-care, like I said, dietary, exercise, alcohol or drug abuse are in fact delivered to Aboriginal and Torres Strait Islander people as a set of behavior change, which again, it's done in a level with the rich tapestry that Indigenous people are happy to receive. These are just two amazing initiatives in Australia. There are, like I said, many more. But I also wanted to bring out Singapore. Singapore is launched a social prescribing initiative meant exactly to do that, meant to keep people away from and outside the healthcare system. In essence, the healthcare system, Singapore, imagine, is a small island with 5 million or so, maybe more, 5 million people, overcrowded, beautiful, great society, very much keen on the environment and very much with the social housing, etc. So it's a very social, good community, very regulated. Of course, there are, like I said, 5 million people in a small island. And so with a growing population, the impact of social prescribing is even more so accepted because, again, people need to learn how to make social behavior changes and health behavior changes without necessarily referring to a GP. And that has in turn made it possible for not only an incredible saving from the point of view of public health, obviously, but also from the point of view of reducing the waiting list for people unwell to reach out to healthcare centers. So the initiative is amazing, it's holistic. There are organizations that live outside the healthcare system or medical centers, so to speak, a hospital, who are in fact they are dedicated to improve the lifestyle of this of a whole lot of people who really don't need to have a pharmacological intervention. It's just behavioral, really. So, okay, I don't know if I've gone beyond my time.
No.
Sorry, I just put it all in.
No, you're okay. You're okay. No, it's fabulous to have the context there, like from Australia to Singapore, across Asia, and it's because we want to give those examples, and that's what this panel is about: is to try and like get different perspectives. You know, we have a European, we're trying to listen and learn from each other. So it's fabulous that you can give that insight. I want to go back to Julie now in London, because myself and Julie have started to work with a group of individuals dedicated to this cause, to start the initiative in London. And Julie, just listening to, Maurizio, Andy, and Manuela, does this give you encouragement? I know we had a very good call on Wednesday. What's your thoughts about, the growing movement that is Global Social Prescribing Alliance?
I think that it's absolutely, you know, like it knocks me for six really, because I used to run a charity many moons ago, and we were doing, it was community outreach advocacy, and social prescribing is very much the same, but on a very focused level. We were in London, and just hearing from our colleagues here today, it just goes to show you how much social prescribing can change the world. Really, it can change people into people that are quite unwell because society has made them unwell, or it can actually alleviate them when they're feeling well because the right services are in place for them. And, you know, like one of the gentlemen on the call said, it's really important that we look at other areas of services and other areas of one's life, because things like housing, health, social care, education, employment, and the criminal justice system, all of those things are areas that social prescribing is at the centre of it, and can be at the centre if it's not already. Social prescribing, I can speak from somebody that's used a social prescriber. Coming, you know, I am a disabled person. Um, I have long term conditions that I have to access both health and social care services. So I have the lived experience, and I'm speaking from somebody who has the lived experience of accessing social prescribing and going out and talking to other people that are working within that field. And I'm going to be frank, the social prescribers are people themselves. They give peer support. They are, some of them are people with lived experience, but even more so, they're not all getting the right support because of the way the system, the statutory systems are set up. And I think that training is key. It really is key for them. And it's also important that the statutory sector recognise the work that social prescribers do, and the social prescribing area as a whole. It's one that should not be missed. Um, it's just vital that we find ways and layers to bring in, I would say, community ambassadors to work with the social prescribers, so they've got people that have their backs, so to speak, because they're out there on their own in the big wide world. They're out there on their own,
And
and I think it's important. It's vital that we have ambassadors that can back them up, can help them to access areas that statutory sector service providers can access. Yeah, yeah, that's me.
fabulous, Julian. I think that just brings us nicely onto, Andy, the sort of discussions we were having during the week. And I just wanted to bring you in to just get your thoughts from the Northeast perspective, because I think there's been for many years now, and I think this is sort of where we're getting to. For many years, like in the voluntary sector, there's been a sort of, there doesn't have the ambition to go big and to have that impact. And I think this social prescribing alliance gives you that platform to actually widen the scope.
Mm.
Maybe you have a few words on that.
Yeah, absolutely, Gareth. And Signal actually works right across the UK. I happen to be based in the Northeast. I'm a Northeast chap. But I think what this network and the type of work that we're connected with is almost creating a liberalisation. And Julie quite rightly talks about social prescribers out there feeling alone. And what we've got to try and do is get this movement that allows people to be liberated, but at the same time know there's a massive network out there who are supporting them and doing very similar things. And I think our conversation this week, Gareth, came to the point where the voluntary sector probably have been living on the scraps for too long and are formidable at relational services, formidable at impact. And I think if we take one thing away from this conversation, or I will, it's about that liberated approach to let's not look at the barriers and boundaries, let's go for it. Because I think there is no alternative other than waiting for welfare state to get its act together. And that ain't going to happen overnight. We have to get out there and be very liberated in our approach.
Yeah, well, I just wanted to add to that, Andy, just because I think just building on a conversation. I mean, we're working with a colleague, Lee, who'll speak later, but he'll give an insight into the sort of impact investment opportunities that are available. And I'm super excited. I mean, the UK government launched one last week, a fund which is match fund with private capital, 500 million, and 500 million is coming from the private sector. And I'm sure there's more instruments on the way. I can assure you there is. And Manuela, let me come to you. Just from your perspective, I mean, you're heavily involved in health literacy. How do we bridge, social prescribing, health literacy? How do we engage communities? And then just from what you've heard from colleagues, and I mean, and you're a fellow Italian, Maurizio. I'm sure you can connect after this. Are you excited for the future with the Global Social Prescribing Alliance and the platform it gives?
Yes, look, thank you. That's really an excellent question. So health literacy is, well, we could stay here for months talking about health literacy, but basically it is, in a very simplified way, an essential component for empowering, for improving knowledge, for empowering the willingness of people to take, I'm not saying matters in their hand, but to take educated matters in their hand. I'd just like to say this. Social prescribing is wonderful. It's a concept, like I said, that's represented in various countries. Yes, it's not really quite matched with investments and structures yet, but it's certainly coming. It's already existing somewhat in some ways, but is the how to get there. This is where health literacy is the bridge, if you like, to engage, again, going from a welfare state type of concept into a dynamic and engaging society that really seek out wanting to be well, which and well-being is a human right, by the way. So, and I like to say that a lot of these initiatives, and I come from the point of view of implementation research, is really, really important that it is co-designed. We really need to ask, we really need to really understand if it is so simple to say to somebody, well, you do not need to go and see a GP, you do not need to go and through the healthcare system, if all you need to do is to know the basic of, let's say, moving or going for walks or going, just doing some exercise. The question is, yes, health literacy will help because the person will understand how important it is to do so, how great is preventing issues, but how to do that. We want to hear it also from the people where this organization are going to be, and many more structures and many more fundings are going to go in this direction. So let's not assume what we know, and let's not assume that's what these initiatives make a lot of sense are necessarily funding in the audience. Let's hear from them. And so when I mentioned before initiatives across Australia for Indigenous people, well, it was only really when it started to be co-designed when we started asking, how can we help? What do you need? Then really these various initiatives that's called under the umbrella of social prescribing started flourishing.
Thanks, Manuela. I mean, I just wanted to try and so let me just come back in here. Let all the learning from Manuela in Australia, Andy in across the UK, and Julie. Maurizio, how are you going to apply this to Italy?
Applying all these lessons and applications possibilities in Italy in a strategic view, it could be simple and easy because there is a strong evidence of the need we have about them, and especially I want to be back, Gareth, with the topic that Andy touched on the first intervent about data, no? Because really the data digital divide is a real problem, and even in my I spoke about it, but it's a very deep the difference between what we say and what we practice, because we created even frustration in a lot of people that for going to access to health activities have to use data, and they are not capable of it, and it's we are like to seem stupid, no? And it's the worst thing that we can do for the citizen, letting them feeling stupid of themselves. And it's because we are not doing simple things, informing and creating programs that are not good for technicians, but must be good for citizens. And the real difficulty is to transfer this content to a policy and stakeholders, politicians, and so on, that are normally using health in the diagnosis and care only perspective. You know that I will have contact, I had, and I will have contact with many of them, but sometimes the difficult thing for me is that I seem to speak another language. There is another fact that they are not too much ready to listen. But so it's simple in theory because the way is clear. We need it. Sometimes I hear people, even surgeons and so on, they say, "But what do we want? We have the one of the older people in the world, so do we want to live till 100 years and so on?" It's not a problem to live to 95 in average or 100. The problem is to live well what we live. And we have to create this type of culture. So it's a simple way in general. It's a difficult way because people seems not to listen, not to have the willingness to listen. So the first thing, Gareth, is to create this environment in which we can connect with some people who want to listen and want to apply this. For me, it's not a problem of solutions, it's a problem of possibility of application. But we have to work about it. And you know that our program is about these things.
Thanks, Maurizio. I think it's fantastic to see the progress that's been made since our event in Bologna. You've been championing that and doing immense work on the ground. Let us do a wrap up here. I'll start with Julie. Julie, just some final thoughts and a sort of call to action.
Wow. I think that we need to have some kind of commitment, a worldwide commitment from our parliamentary representatives, I'm not sure what they call them in Australia, in Italy, in the Caribbean, but in the UK, there must be a commitment to make sure that social prescribing is not just an individual drive. Social prescribing is a community within itself. They're collaborating all the time. And I think that it just makes sense that our parliamentary leaders listen. Well, first, stop, look, and listen. It's time now. It really is time because people are suffering because we don't have the right support in place, the right local support. And when local support ripples, it goes regional. When it ripples again, it goes national. When it ripples again, it goes global. And so we need to bring our communities together, and they need to also, we need to make sure that our communities know their rights, their human rights, to knowledge.
Completely agree. And I'm sure everyone on the panel agrees as well. So let me wrap this up because we've got only about 2 or 3 minutes left. So Andy, I'm going to pop to you for 30 seconds of a wrap up, and then I'll go to Maurizio and then Manuela. Andy, final thoughts and call to action.
Yeah, I think this is something that we can all do right here, right now, and across our organisations with social prescribers, etc. And that is start and finish with asking the question, what matters to you?
I love that. Maurizio, let me go to Maurizio.
I really hope that the vision of WIS and Global Social Prescribing Alliance will match very well, and so we will program international activities. So my call to action is let's do them, let's do even in a hurry, because we have a world in which the other things, even the worst and the really bad ones, are going with a great speed. We have to create some very good things, and we have to create in an international way, because as Italians or Australian or uh, British and so on, we, in my opinion, can do very much fair. We have to create in an international way, so let's do it. Create some programs that apply in an international mood.
Manuela, final word from you. Just some action points and sort of a call to action.
Yes, well, to action. Look, I think we need to bring the tenet of social prescribing to politicians, to international organizations. We need to get them on board because, that's where what we call the money come from, really, making them understand that a well population is in fact not only morally correct, is not just a human right, but is also will alleviate a whole lot of costs related to healthcare systems, which really are sinking for too many, the demands is too high. So if we turn this around from the top down, but also from the bottom up, so community-based organizations, diffusing, like I said, the principles of social prescribing across the board, from ethnic communities to larger communities, people receive it well. So connecting the two, and maybe that's what, Gareth, that's what your job is, really, is connecting it and putting the voice out there. Yes.
Thanks. That's no easy task. So I need a lot of help, and and we're all in this together. As I said, we're all part of the same network here. So the great news is, of course, go onto the website, go onto the platform. We're opening up the community. As Maurizio, Andy, and Julie have said, we all have to come together. Take a look through the website. You'll see how to onboard. You can become a community champion. You can become a volunteer. We have the networks going. We're setting up the WhatsApp channels. So please join us, get involved. Everyone's invited. So let's mobilize and let's do it quickly. As Maurizio said, let's create something at force and at speed. So let's move this along the agenda. That, of course, will bring the capital and the investment that we need. So look, I'm going to jump off for a short break. We'll be back on in about 10-15 minutes for our next panel. I do hope you can join us for the next session, where we'll be discussing how do we build social prescribing networks around the world, and best practices and strategies. So do join us in about just over 13 minutes. From myself, Andy, Maurizio, Manuela, and Julie, I just want to say thanks. I'm very grateful for the panelists, for all the discussion, and we'll see you in a couple of minutes. So thanks, everyone.